Good morning. I am Dr. Swami Iyer. We are at the American Society of Hematology meeting in Orlando in December, and I have with me Dr. Srinath Sundararajan, who's a third-year fellow at the University of Arizona, and he has a very exciting abstract that he's presenting at this meeting. And so we're having this discussion of his abstract at the auspices of the IACA booth in ASH. Welcome, Srinath.
Thank you, Dr. Iyer, for having me, and it's a great pleasure to be in this booth to talk about my research study. I'm a third-year fellow at the University of Arizona. I'm presenting an interesting meta-analysis research study on neuro-oral anticoagulants compared to conventional therapy. About 3 years or so ago, patients who needed anticoagulation, the standard of care was warfarin. That's the only available oral anticoagulant. And in the last 3 years or so, we have a flurry of new drugs that are available. Some of them are direct thrombin inhibitors, like dabigatran, or some of them are 10A inhibitors, like rivaroxaban, epixiban, and the latest one is edoxaban. And all of them are now FDA approved for treatment of venous thromboembolism, and some of them are used for prevention of stroke and atrial fibrillation. Our main question was, are these drugs effective and safe in patients with renal insufficiency? And the main rationale for this question is most of these trials excluded patients who had severe renal insufficiency, anyone with a GFR below 30 or so. And what we were trying to find out is in patients with mild and moderate renal insufficiency, how effective and safe these drugs were when compared to warfarin.
That's fantastic. I mean, just to try and have a meta-analysis, how did it go about it? Looking at the abstract, it looks like you had 47,000 patients. It's a huge number. How did you go about it?
Well, there's a systematic method to include trials in meta-analysis. So we go to publicly available databases such as PubMed, Medline, Sinhal, or Embase, and look for search for trials which had neuro-oral anticoagulants such as rivaroxaban, epixiban, or edoxaban, and then we include trials which compared these agents with conventional treatment, either Lovenox or enoxaparin or warfarin. And we try to get those trials which had reported renal parameters such as what's the creatinine in these patients that included, and what was the outcome and safety in these patients based on the creatinine levels. We use the European Society renal insufficiency classification, which was what the trials had used. And patients who had creatinine above 50 to 70 were considered as mild renal insufficiency, and 30 to 50 were considered as moderate renal insufficiency.
So what are the findings?
So we were able to identify 16 randomized control trials, which had about a little over 115,000 patients, which is a pretty big sample size. And among them, about 48,000 patients had renal insufficiency, either mild or moderate. And our efficacy endpoint was looking at incidences of venous thromboembolism in these patients, on patients who were treated for venous thromboembolism, and then arterial thromboembolisms on patients who had AFib. Our safety endpoint was looking at bleeding risk in these patients who were treated with neuroanticoagulants compared to conventional therapy. And what we found was in patients who were treated with neuro-oral anticoagulants, the bleeding risk profile was better compared to warfarin, which is a significant finding, and it's good to know that it's consistent with other patient population too. If you look at patients who did not have renal insufficiency, the bleeding profile is definitely better in oral anticoagulants compared to conventional therapy, and that's the same finding we were able to find. Both in patients with mild and moderate renal insufficiency, the bleeding profile was better with neuro-oral anticoagulants compared to warfarin.
Was it a counterintuitive observation, you think? Was you surprised by the data?
Our hypothesis was this is going to be better, so it was on expected lines, which was reassuring.
And so, and considering that there's so much database and heterogeneity, how did you harmonize all the data sets?
That's a great question. So any meta-analysis should take into account the heterogeneity of trials, because we are not using a homogeneous population. We are including about 16 randomized controlled trials which were done across the world, and the study population were different. So we use the randomized random model instead of the fixed model, assuming that our population is not homogeneous. And as we see, the curves would be a random effect curve for the first plot. And that's how we were able to overcome the heterogeneity within the population to kind of give us the result in a more inclusive way, rather than assuming all our population is homogeneous.
Excellent. This is an outstanding observation, because it's going to be very helpful for real-world practice. And I think most practitioners, hematologists, nephrologists wouldn't be afraid to use the newer anticoagulants in the setting.
And that was our goal of study, to do something which is clinically relevant that most people can use. And this is a clinical question I had when I was starting my fellowship. And hey, this patient has creatinine which is 2.5. Can I use a neuro-oral anticoagulant? And I think this data is helpful to answer that question.
Excellent. Just a last question. Were there any bleeding seen that was significant? Obviously, the overall trends are not significant compared to warfarin, but were there bleeding risks seen that were critical in either warfarin or in the new ag?
Well, the bleeding risk included severe bleeding, life-threatening bleeding as well, and so it was there in both arms, and that profile was better with the neuro-oral anticoagulants compared to warfarin. If you look at incidences of arterial thromboembolism, which would be an efficacy endpoint in these patients, say if someone has atrial fibrillation and they are on a neuro-oral anticoagulant compared to warfarin, you want to see how many patients develop a stroke. And that profile was actually better with neuro-oral anticoagulant compared to warfarin, meaning they're not only safer, but they're also probably more efficacious in these patients compared to conventional treatment such as warfarin or Lovenox.
Excellent. That's a great job. Congratulations.
Thank you so much.
And I think this should be published very soon so people can get to hear and start using this as a reference point.
We are in the process of getting the manuscript done pretty soon, and hopefully this will get published pretty soon. Thank you so much.
Thank you, Srinath, and all the best.
Thank you.